Welcome to this deep dive. If you're listening to this, you are a resident preparing for the FRCS Plastic Surgery Board exams, and you know the clock is ticking.
Absolutely ticking.
Right. So our mission today is, well, it's highly focused.
hmm
This is a high-yield, rapid-fire revision session on hypospadias.
No fluff today.
Exactly. We are going to drill you on exactly what the examiners are looking for, from embryology and anatomy, all the way through to the specific mechanics of urethroplasty techniques.
You need to know this stuff cold.
You really do. Now, before we start, some quick housekeeping. Make sure you press follow on the show right now. And, if you learned something valuable today, leave us a rating.
Please do.
Also, if you are serious about passing these boards, you need to get a premium subscription.
Yeah, that's where the real prep happens.
Right. Use it to listen to our journal club and clinical cases, deep dives. Those are absolutely essential for your Viva prep.
You can't skip those.
Okay, let's unpack this. We're jumping straight into the clinical definition and the presentation you'll see on the ward.
Yeah.
So what is the classic triad that defines hypospadias, and what variants should the resident be aware of?
So the absolute baseline for the exam is that classic triad. You need to confidently state that hypospadias is defined by, first, an abnormally proximal urethral meatus.
Which is usually on the ventral aspect, right?
Right, ventral aspect of the penis or scrotum. Second feature is a hooded, ventrally deficient prepuce. And the third is ventral curvature of the penis.
Which we clinically call chordee.
Yes, but let's clarify that last point because the terminology constantly trips people up in the Viva.
It really does.
You have to be incredibly precise with the examiner. The term chordee translates to curvature. It does not mean cords of fibrous tissue causing that curvature.
Which is a very outdated way of thinking about it.
Completely outdated. And this is a vital distinction for your surgical planning. Because while the curvature itself can be corrected, you cannot simply go in and excise chordee as if it were an anatomical structure.
You're correcting a geometric deformity.
Exactly, not removing a specific band of tissue. And while that classic triad is your baseline, you cannot overlook the clinical variants.
Specifically, the megametus intact prepuce variant, right? The MIP.
Yes, the MIP variant.
That one is a classic trap, both in the exam and in the clinic.
Oh, massive trap. With the MIP variant, you have a child presenting with a completely normal-appearing foreskin.
No dorsal hooding at all.
None. But that normal prepuce actually conceals a glandular or distal shaft hypospadias right beneath it.
So if you have a junior resident who doesn't retract the foreskin carefully during an examination under anesthesia,
or worse, someone blindly performs a routine circumcision on that child,
they instantly throw away the vital reconstructive tissue needed to fix the hidden defect.
it's a disaster. And it's exactly why the FRCS loves to use it as a disaster management station. You need to recognize it immediately.
Okay, let's talk numbers. What are the epidemiological numbers and etiological factors the examiners will definitely look for?
You need to know the baseline frequency. It affects approximately 1 in 300 live male births.
And most of those are distal, correct?
Yeah, the vast majority, roughly 85%, are distal.
And the examiners will pivot straight from that baseline into the associations.
They always do. You need to state that approximately 10% of hypospadias cases present with an inguinal hernia.
Compared to the general population where it's only, 1 to 5%?
Exactly. Even more critically, 20% of these patients will have other abnormalities of the genitourinary tract.
Most commonly, cryptorchidism.
Right. But you need to know how the percentages shift. Cryptorchidism affects 3% of patients with a distal defect, but that jumps significantly to 10% in patients with proximal hypospadias.
What about the etiological factors?
Well, the major one to cite is in vitro fertilization. Hypospadias occurs 5 times more commonly after IVF.
And that's likely a combination of hormonal manipulation and the underlying paternal subfertility, right?
Exactly. You also need to mention placental insufficiency. Look for associations with low birth weight, preterm birth before 37 weeks, and maternal factors.
Like maternal obesity, diabetes, and hypertension.
Spot on. On the molecular level, they'll want to hear about genetic and hormonal pathways.
So defects in testosterone synthesis and androgen receptor deficiency.
Yes. Genetically, point out mutations specifically in the FGF8 and FGFR2 genes.
Which are crucial for normal tubularization.
Right. And finally, exogenous estrogens. Exposure to increased levels disrupts that delicate androgen balance during gestation.
Which brings us perfectly to the embryology. How does the embryology explain this defect? Walk us through the internal and external development.
If we connect this to the bigger picture, it all starts before the 6th gestational week when the embryo is sexually indeterminate.
Then the gonads arise from the genital ridges.
Exactly. For the internal organs, the master switch is the SRY gene on the Y chromosome. It dictates everything that follows.
It induces the Sertoli cells, right?
Yes. The Sertoli cells secrete Mullerian inhibiting factor, which causes the paramesonephric or Mullerian ducts to regress.
Because without that regression, you get female internal structures.
Right. The SRY gene also induces the Leydig cells, and their primary job is to secrete testosterone.
And the testosterone drives the mesonephric or Wolffian ducts. For the exam, the mnemonic here is SEED, right?
Correct. Seminal vesicles, epididymis, ejaculatory ducts, and ductus deferens. That's your internal development.
What about the external development?
Externally, male differentiation depends heavily on androgen receptor signaling. The genital tubercle forms the penis.
But the crucial mechanism for hypospadias is the urethral folds.
Yes. The urethral folds must fuse over the urethral groove. Think of it like a zipper. This fusion has to happen in a very specific direction.
Proximal to distal.
Exactly, proximal to distal. When that fusion arrests prematurely, the zipper stops. And that is exactly where your hypospadiac meatus ends up.
Okay, let's quickly review the relevant cross-sectional anatomy of the penis. Examiner asks you to describe the layers. What do you say?
You start with the 3 tissue cylinders. 2 corpora cavernosa dorsally, and 1 corpus spongiosum ventrally.
Which houses the spongy or penile urethra.
Right. Enclosing those cylinders is the dense tunica albuginea. Superficial to that is Buck's fascia.
And Buck's fascia is critical because it contains the neurovascular bundle.
The deep dorsal vein, dorsal arteries, and dorsal nerves.
And superficial to Buck's.
The dartos fascia. And in an anatomy station, always mention that dartos fascia is continuous with caulis fascia and the perineum.
Essential point.
Yeah.
So when a resident is examining a child in clinic, what are the critical steps and absolute do-nots?
First step, assess the overall penis size. Next, immediate priority is checking for bilaterally descended tests.
But you must explain your technique to the examiner.
You absolutely must. It has to be a bimanual examination. You place one hand over the deep inguinal ring to close it off, while your other hand sweeps the scrotum.
Because if you don't block the deep ring, you can force a mobile testes into the abdomen and falsely document cryptorchidism.
Exactly. You also need to actively check for hernias. Roll the tissue looking for the silk glove sign.
Meaning a patent processus vaginalis. What about the absolute rules? The do-nots.
Rule 1, do not separate preputial adhesions during an awake exam.
Yep.
You will cause scarring and distress. Rule 2, tell the parents not to circumcise the child.
Because we need that tissue for reconstruction.
It is your primary reconstructive life raft.
So when do we need to investigate further? When is it more than just a routine hypospadias?
There are 2 main red flags. First, proximal hypospadias plus cryptorchidism.
That's a high likelihood of a disorder of sex development or DSD.
Correct. You need a pelvic ultrasound, a karyotype, and serum electrolytes to screen for congenital adrenal hyperplasia.
Missing CAH in an exam is an automatic fail.
It's a life-threatening salt-wasting crisis, so yes. The second red flag is hypospadias plus other anomalies, like abnormal facies or anorectal issues.
Meaning it's likely a syndrome.
Yes, and that child needs an upper urinary tract ultrasound.
Okay, let's move to the operating theater. Surgical strategy. What are the primary aims of surgery, and what is the current consensus on timing?
The aims are functional and aesthetic. We want a normal aesthetic appearance, specifically a slit-like meatus, not a round hole. We want normal erection and sexual function, and a normal forward-directed urinary stream.
And the time.
The U.S. favors 6 to 12 months. Europe leans towards 12 to 18 months.
But in expert centers, healthy boys over 50 weeks gestational age can be done as day cases.
Precisely.
How do we accurately assess and correct tortiate intraoperatively?
The absolute first step is always degloving the penile skin down to the base.
Because apparent bending might just be soft tissue tethering.
Right. Once degloved, you assess the true severity using Horton's test. Place a tourniquet at the base and inject sterile saline into a corpus cavernosum to induce an artificial erection.
And that dictates the algorithm.
Yes. If the curvature is less than 30 degrees, you manage it dorsally with a Nesbit dorsal plication, a midline tunical tuck.
But if it's greater than 30 degrees?
A dorsal tuck would shorten the penis unacceptably. You must do a ventral lengthening. Make a transverse incision through the urethral plate, occasionally incising the tunica albuginea, and cover the defect with grafts or flaps.
Here's where it gets really interesting. Let's break down the high-yield urethroplasty techniques. What are the go-to procedures for distal hypospadias?
The absolute workhorse is the tip repair, the tubularized incised plate or snodgrass.
Walk us through the geometry of that.
You make a deep midline longitudinal incision straight down the center of the urethral plate. This acts like a hinge, widening the plate.
And it spontaneously re-epithelializes.
Exactly. You free the lateral edges and suture them over a catheter into a tube. But the key exam point is where you start that suture line.
You suture distally up to 3 millimeters proximal to the plate end, right, to avoid stenosis.
Correct. If you suture to the very tip, it will stricture. And finally, you cover it with a dartos flap for waterproofing.
What about the ANGPI?
Medial advancement and glanuloplasty. Used strictly for very distal mobile meatuses with no chordee. It uses the Heineke-Mikulitz principle.
Transverse suturing of a longitudinal incision.
Right. It advances the meatus without tubing new tissue.
And the Matthew.
That's your classic flip-flap. A distally based skin flap on the ventral shaft flipped over to create the superficial circumference.
Let's touch on the urethral advancement, the beam procedure.
That relies on circumferential dissection. You can gain about 2.5 centimeters, but it requires a perineal incision to mobilize the bulbar urethra.
If you don't release it proximally, dragging it forward causes tension and secondary curvature.
Exactly.
And for proximal hypospadias.
It depends entirely on whether the urethral plate is preserved after chordee correction. If it's intact, use a proximal tippy or an onlay preputial flap.
But if it's transected or excised?
Then you need a tubularized preputial flap, or, far more reliably, a two-stage repair, like the BRCA or Cloutier.
Detail that two-stage repair for us.
Stage 1 corrects the curvature aggressively, widens the plate, and resurfaces the massive ventral defect with a full-thickness inner prepuce skin graft.
Because it's hairless and accustomed to moisture.
Exactly, you let it mature. Then, stage 2 happens 4 to 6 months later. You incise a U-shape into that mature graft and tubularize it.
Perfect. Finally, for the complication station, what are the early and late issues, and what are their specific rates? You need to know these numbers.
You do. Quote, a 10% complication rate for a distal tip P, 15% for a two-stage repair, 20% for a proximal tip, and 25% for preputial flaps.
Early complications on the ward.
Bladder spasms, hematoma, wound dehiscence.
And erections can tear the suture lines.
Yes, suppress those with cyproterone acetate.
Late complications in the clinic.
Fistula is the most common overall. Then urethral stenosis, usually right at the proximal anastomosis site.
And diverticular.
That's ballooning of the urethra during voiding. It's caused by a distal obstruction or turbulent flow pushing outward against the reconstructed wall.
This raises an important question, doesn't it?
This raises an important question, yes. It's about the evolution of our specialty. For decades, surgical dogma stated that chordee was caused by fibrotic bands in the urethral plate, so surgeons routinely excised it.
But that's changed.
Completely. Recent histological exams of those resected plates show highly vascularized tissue with absolutely no fibrosis.
Which completely shifted the paradigm toward preserving the urethral plate whenever possible.
Exactly. It should make you consider how many other surgical dogmas are waiting to be disproved by basic histology.
And that is exactly why we study the fundamentals. That wraps up our rapid-fire revision on hypospadias. We want to hear from you. Drop down into the comments section below and leave a question regarding any specific surgical steps or anatomical planes you want clarified. We built this deep dive to help you crush your FRCS boards, so utilize us. Keep studying, stay focused, and we'll see you on the next deep dive.